Good evening, everybody. Today we are going to concentrate on a very important topic. At this point of time, every year we are losing nearly 1 million children at the time of birth within first 1 month. It is very worrisome that even with so much of advances, nearly million children are at, losing their lives in the first 1 month. And I would like to ask the participants what they feel, whether India is doing great or India is not doing good as far as neonatal care is concerned in the community setup. So you can just unmute and tell us, or you can give a thumbs up, or if you feel it is good, or if you are not feeling good that India is not doing great, you can just mention some other way. You can just put a message. Some. So can you just unmute one of you to one or two people can unmute and tell us whether India is doing great or India is not doing good. Let me help you out. Swati has put us doing okay, and let me help you out. India contributes to 1/4 of the neonatal mortality rate. Swati, still you want to hold your statement that India is doing good? India is contributing to 1/4 of the neonatal mortality of the whole world.
We're getting better, sir, so soon we'll reduce
Okay,
it
right.
to be.
Sure. And that is very reassuring. And one more statement I want to put to you. In 2017, Lancet came with a publication that India will not be able to achieve the Sustainable Development Goal 2030, single-digit mortality. Still, you want to hold with the statement that India is doing okay. We got another 7 years more. Mortality is 20. At no point of time you'll be able to achieve single-digit mortality. So, do you still want to hold the statement that India is still doing good as far as neonatal mortality or neonatal care is concerned in the community setup? Or any difference in opinion? Swati, you
Hmm,
can.
maybe not, sir. Maybe it's still ambitious, but we need to have extremely better penetrative neonatal care.
So that's a good understanding. So the numbers put by Lancet and the mortality we are having and the time limit of 7 years to go before we reach 2030, whether SDG has achieved, may look very lucrative. We may not have the picture in our mind that we may be able to do good. But looking back, there are some enthusiastic steps by India when ENAP, Early Newborn Action Program, was started in 2014 by the global campaign. They wanted a mortality of less than 12 per thousand. But India was very enthusiastic. India wanted a single digit mortality of by 2030. The enthusiasm has not failed to bear fruits. It is very encouraging to know that in the last 30 years, 1990 to 2030, the decline in NMR is 64% in India compared to only 54% on the global level, which with giants like China, Japan included, we are still achieved a neonatal mortality 64. And the numbers are more in case of IMR, 70% decline compared to only 68% at the global level. And more than 70% decline under 5 mortality last 30 years compared to a mere number of 60% at the global level. So these improvement things are really encouraging us that India is not doing bad. India is doing good as far as neonatal care is concerned. In 2019, UNICEF has came with an important statement that nearly 50% of neonatal death can be averted by 4 major steps. One is care of the antenatal mother. When the mother comes to labor room, take care of her. And take care of the delivery, labor room care. Number 3, take care of the baby and the mother after delivery. Take care of the sick baby. There's a 4. So what Dr. Ishita is going to discuss will be all the programs will fall in 4 major criteria: care of the mother, care of the delivery, care of the postnatal mother, and care of the newborn baby. So just Ishita will be talking in detail. Just 1 or 2 minutes, I'll just tell you. Care of the mother, the program of giving free iron folic acid tablets, the program of pre-conception care free of cost, the program of antenatal checkups regularly, and the program of free transport of mothers to delivery room. This much is there. And if you take the Rashtriya Kishore Suraksha Karyakram, or KSK, like what RBSK, in the new India policy, there are 3 programs, and one of three programs apart from RM and CH is RKSH, that is Rashtriya Kishore Swasthya Karikram. ASHA worker was given the role of distributing sanitary napkins at one rupee per napkin. You may think that this is a very small step. What difference it would make in NMR by just providing a napkin to the mother, to the adolescent girl? So what the thought process was that giving a sanitary napkin will reduce the reproductive infection, which may prevent future infertility and precocious unhygienic early UTI or recurrent pregnancy loss and early very preterm deliveries. All this can be prevented by just maintaining a hygienic menstrual hygiene. That is the thought process for the antenatal mother as far as concerned. Concerning delivery, that's a beautiful program, Lakshya, labor room care, Lakshya, and there is a 21,000 newborn care corners developed in India, exclusive for taking care of newborns at time of birth. There is a facility development. FPNC program has been running. Madhya Pradesh, Rajasthan, Uttar Pradesh, and Bihar are the prior consonant areas because these are the areas where your NMR is high. So this FPNC program is running all over the year, in particularly in Madhya Pradesh, where they are almost when I go for the FPNC program last 2 years back, almost all nurses has been trained. They are attending FPNC program second time. Then I asked, almost all nurses has been trained, sir. As per the regulation, somebody has to come. We are coming for second time. That is the FPNC program for the delivery. And after delivery, that's a very beautiful program, Suman, provision of free medications for the mother and care of the mother. And last, baby care. Baby care, India has gone one step ahead. The sixth pillar, apart from the five pillars of ENAP, India has put a sixth pillar, sustain of care beyond newborn period. For example, RBSK, Rashtriya Bal Suraksha Karikram, has gone to the level of preventing congenital deformations, identification disorders early, development disorder care, and nutritional care. That is beyond neonatal care. This is the sixth point of INAP that is exclusive only for India. So, and last is Muskan program, quality of care. We do some work, we do with quality. The Muskan is a program which has improved quality of initiative. So, antenatal care of the mother, delivery care, postnatal care, and delivery care of the sick newborn. So, I invite Dr. Ishita, Senior DM Resident, to please enlighten us through the various programs. Over to you, Dr. Ishita.
Thank you, Rabindran sir. I'll just share my screen now, start the presentation. Is the screen visible to all?
Yeah, it's visible.
So I'm Dr. Ishita Singh, second year DM Neonatology resident at SRFC, and I'll be talking about a seminar on community neonatology programs at present. So as sir has already given a very riveting introduction, the important point that we need to always remember is disease can affect all of us equally as long as the social orders are maintained equally. And of course, we know because there are severe disparities in India, because of the burgeoning population, not every mother, not every neonate has access to the same level of care in which we all are being trained actually at present. So these programs are hard at work to try to bridge the gap to ensure every newborn has as good a survival as to the ones that we're delivering in most of the tertiary care centers. So I'll be going through the current scenario at present and focusing on the current programs with a little bit of talk on the future direction. So the country's health is under the ambit of Ministry of Health and Family Welfare, which has propagated the National Health Mission, which is further divided into two, which is the NRHM, the Rural Health Mission Program, and the National Urban Health Mission Program. So coming to the current scenario, before I come in, just like to discuss a poll. What do you think is the current NMR of India as per the sample registration survey? Okay, so 70% have almost participated, and but the answer is almost close. The answer is most of us have got it right. It is 20 per 1,000. The previous SRS values were 22.
Ishita, you could share the poll so that everyone can see.
Okay, ma'am.
If you click there, share the results. Okay, if you're not sure, leave it there. Yeah, we are able to see.
Okay, so most of us have got the answer correct, which is 20. As per the NFHS 5, however, that is the National Family Health Web 5, the value is slightly different as 29.5. But as per the SRS, which is a more reliable data collection authority, because of their wider population and sample size, the value is actually 20. So coming to the causes of neonatal mortality in India, most commonly are prematurity and low birth weight related, followed by birth asphyxia and birth trauma, followed by neonatal pneumonia, and the rest being communicable diseases, sepsis, ill-defined causes, canal anomalies, and diarrhea and other causes. As I already mentioned, although we had the target to achieve less than 12 NMR for the country, and 6 states have already achieved that. The leader being Kerala, followed by Delhi, Tamil Nadu, Maharashtra, and JNK and Punjab. So many states are actually doing much better, and it is very heterogeneous across the whole country. But the progress, as Sir has mentioned, has been quite striking, and we hope that the momentum continues. So coming to the health programs at present, the NHM promulgates 3 main divisions of health programs, which is the RMNCH plus A, under which most of the maternal and child programs are included. Our focus will be on the child health programs. So RMNCH plus A adopts the concept of continuum of care, which states that every individual needs to be looked at as a constant continuum to be given medical health and support at every stage of life. Starting from the adolescent age, going over to the one that adolescent female becomes a mother and then gives birth to a newborn, and then newborn will grow up to become an infant, adolescent, and possibly a mother in their own lifetime. So targeting them completely at any one given point of time will ensure that the health is maintained for the future generations as well. So estimated 26 million of children are born every year. That is why the health services are absolutely overburdened. So critical services need to be made available through community outreach and available at home as much as possible. So under RMNCH plus A, which are the neonatology specific related programs, facility-based newborn care, mother newborn care units, RBSK, JSSK, NSSK, IMNCI, and facility-based IMNCI, home-based newborn care, Indian Newborn Action Plan, and also the last and but not the least, the increased focus on family participatory care, along with quite a few ongoing initiatives for continuous quality improvement. So coming to JSSK, the Jani Shishu Raksha Karyakram, which was launched in Haryana in 2011 with the single sole motive of improving institutionalized deliveries. As more mothers will deliver in a healthier environment, our newborns will be healthier. And the results have been the institutional deliveries have increased from 40% to 88.6% as per the last NFHS survey. This program includes cashless services to pregnant women, including normal deliveries and cesarean sections. Also includes treatment for sick newborns up to 30 days. They've also updated the program and included extra care for newborns, infants up to 1 year of age as well. So the 3 Ds are the available drugs, available diagnostics, and available diet for mother and child both. So they can also target malnutrition for growing children up to 1 year of age. Coming to NSSK, which is Navjat Shishu Suraksha Karyakram, was based on the premise and understanding that one of the most important causes of admissions in our SNCUs is because of birth asphyxia related complications. And we are fortunate enough to have access to state-of-the-art NRP training, advanced training in the best institutes with the latest guidelines. But how much of it gets filtered to the primary health, to the lowest level, that is CHCs, at the FRUs, the district health hospitals. So this program primarily focuses on resuscitation, essential newborn care to prevent intrapartum complications. Basic skills are also taught, which include routine care of healthy newborns, initiation of KMC in lower birth weight babies, to early initiation of breastfeeding, infection prevention, cord hygiene, Even they tie up with RBSK as well to sensitize the trained personnel for picking up visible birth defects. If a unit is sick, how to transport, and also for immunization sensitization. So far, more than 1.5 lakh personnel have been trained at different states. Coming to next, IMNCI, which we're all pretty much aware of, which has been a very solid and a very successful program, an integrated approach for child health that focuses on the well-being of the whole child, which includes the assessment, the referral, and the stabilization and the follow-up. However, the next step has been to integrate IMNCI with the facility-based care packages to empower health personnel to be able to take these children who were identified at home-based as a OPD basis. But now when these children are referred, where will they go? They need to be admitted, and now because SNCUs and stabilization units are coming up really well, so we need personnel to work there. But as per the required 4,000 pediatricians, we have only 898. So to bridge the gap, to build the capacity of the health personnel, this program has been at work to train pre-service and in-service existing staffs over a course of 5 days to 11 days, in which they're given training of IMNCI and facility-based management of sick newborns and children as well. So the target personnel are usually the medical officers or the nurses at the FRUs or the CHCs and the PHCs. It includes modules for IMNCI and facility-based cares. Also includes emergency triage assessment and treatment, sick of young infant and care of the sick child. The training can be done at any medical college level, also big district hospital, even private institutes who are dealing with the with significant amount of patient inflow can also be as the resource institutes. So 50% of training time is hands-on, and the remaining half is spent in classroom sessions. So the 9 modules include the known IMNCI packages, and the other 3 are detailed management for even hypoglycemia, airway breathing management, circulation management, shock management, coma, convulsions, dehydration, and newborn resuscitation, transport, and even management of diarrhea, malnutrition, and pneumonia. So now that the personnel has been trained at the facility care package, which all levels can they actually work to impart this level of care? So there are 3 levels, the topmost being the special newborn care units, which should be ideally present in each district, which is the government's plan. Then newborn stabilizing units, at least all first referral units and community health centers should be having it. And newborn care corners, which are being mandatory, at least in all the institutes conducting deliveries, if not managing sick newborns. So what is the scope of working for a newborn care corner is basically to provide warmth. They should have one radiant warmer with an NSSK trained individual where they can even identify and refer at sick or sick baby. One level above that comes to the newborn stabilization units, where the management of low birth weight babies can take place, but more than 1.8 kgs. Sepsis management can also take place, and treatment of NNH. The topmost level is special newborn care unit, where they should be able to manage even infants less than 1.8 kg weight. All those very sick newborns, except requiring mechanical ventilation and surgical intervention. So the infrastructure which has been laid down for the SNCUs, there should be minimum 12 bedded in areas which are having more than 3,000 deliveries per year. 4 additional beds also should be added, and at least 100 square feet area per patient should be allocated, including a step down area, a feeding area, doses workstation area with the side lab, portable X-ray machine, 4 therapy devices also. Ideally, a team of 3 to 4 doctors should be present, with 1 trained pediatrician in neonatology, plus 2 or 3 medical officers, with at least 3 nurses in each shift. All support staff should be present, and all should be trained in NSSK, in facility-based IMNCI, and the FNBC training modules. The budget approximately the government has given forward should be around 51 lakh to set up 1 unit. It does not include the training cost and the staff salaries. So as of now, the bed strength distribution in the country for SNCUs is quite heartening. It has been increasing. For the minimum of 12, it has increased from an average of 13.6 to 15.9, which is heartening. Also, the high performance focus states like Northeast also have increased their bed strengths. Coming to but are they adequately manned by the staff is the question that remains to be seen, as the doctor ratio is only 50% met and the nurses ratio is also gradually increasing. The patient population distribution in SNCUs are actually mix of almost equal ratios of outbound to inbounds, and predominantly being burst asphyxia and sepsis related. Almost 75% of admissions are actually discharged alive, while 6% 6 babies were referred to higher centers. And the sickness profile, many obviously were not well, lost to follow-up was there, but the mortality rate was 12%. And average babies stayed for around 1 to 7 days. Coming to newborn stabilization unit, the level below SNCUs, it's a minimum 4-bedded stabilization unit, which also can have additional 2 beds in the postnatal ward for rooming stable babies. Smaller area, 200 square feet is enough for them, and they should be able to manage slightly bigger babies, more than 1.8 kg, without any complications. But newborn sepsis also can be managed, along with the hypovoluminemia, and just to give KMC and breastfeeding support. 1 doctor trained and 4 full-time staff nurses trained in newborn care should be manning the NBSUs. They should be trained in NSSK and facility-based IMNCI. So the approximate budget for this NBSU will be around 7.5 lakh. Coming to newborn care corners is just at least 1 radiant functioning radiant warmer with the adequate resuscitation kit, with the 1 doctor and 1 staff who are trained in NSSK to resuscitate a well or a sick baby after birth. And they should be in every institute providing a delivery service. The cost they have set forward is around 1.11 lakh for setting up a newborn care corner. So to provide ongoing support to this very important part of neonatal community health, the National Collaborative Center is AIMS New Delhi, and regional centers have also been set up with KEM Mumbai, PGI Chandigarh, ICH Chennai, and Kalavati Saran Hospital Delhi. So the aim is to have SNCU in each district and sub-districts also, which are having a high volume of deliveries, and aim to have NBSUs in all FRU and CHCs. Coming to INAP, which is the Indian Newborn Action Plan, which is India's response to the global Every Newborn Action Plan to prevent any amount of preventable newborn deaths and stillbirths. Target to achieve a single-digit NMR by 2030. Target to achieve single-digit SBR by 2030, which seems difficult, but of course efforts are on way in the form of 6 pillars of intervention, like Sir has already described. The preconceptional care up to care beyond newborn survival. Coming to the other most important pillar of community is home-based newborn care, for whom the soldier on the ground is our ASHA worker, which consists of home visits for delivered babies, either home delivered at the 1st day, 3rd day, 7th, and then the 3rd week, 4th week, and the 6th week of life. For institutional deliveries, 3rd day, assuming to be discharged at 48 hours of life from their institute, coming back to home, and the 3rd day after that, and then the 7th day, and then the 2nd week, 3rd week, every week visit till the 6th week of life. So this is a good opportunity for ASHA worker to be visiting the baby at home, especially to be able to give extra care to low birth weight and premature babies, counseling and ensuring breastfeeding rates are continued, ensuring the immunization is adhered to as well. This home-based newborn care also is a very good opportunity to identify defects which are to identify babies who need early stimulation and follow-up for developmental delay, which is the main focus of RBSK, the Rashtriya Bal Swasthya Karyakram. According to a survey, out of every 100 babies born, 6 to 7 may have a birth defect. That translates to around 17 lakh birth defects. So aiming at early identification is the point of RBSK. And the ultimate hub of the activity will be the district early intervention centers, where all these picked up infants, babies can be pooled and then referred forward to higher centers. So what are the levels of screening in RBSK? Of course, the first level will be at the institute, either the newborn care corner or the NBSU or the SNC, where the baby is being delivered. The medical officer, nurse, or ANM, they can pick it up. Then 2nd level, the ASHA worker. Once the baby is back at home, then HBNC with their home-based newborn care, they can pick up any defects. And 3rd level will be up to 6 weeks of 6 years, and even up to 18 years of life. With the mobile health teams, which should be set up with Ayush doctors, with an ANM nurse and a pharmacist who will be going house to house, villages to villages, to just screen at different intervals to have a checkup of the babies. And also school health system can be roped in, as the school nurses and school doctors also are sensitized about identifying the different kinds of defects, the deficiencies and diseases, the developmental delays. A very exhaustive list of 30 conditions has been set forth, which should be identified, which should be screened and then referred. And similarly, a very easy head-to-toe examination, these charts are also available and given to the ground worker to be able to easily identify any of the anomalies and refer early. So coming to the heart of the program, which is the ASHA worker, the accredited social health activist, who is nothing but a very voluntary community-based functionary who caters to a population of 5,000, but a population of 1,000 if the area is remote. It should be a woman, resident of the village at the age 25 to 45 years of age, should have effective communication skills and formally educated up to class 8. In fact, Asha are among the 6 recipients of the WHO Director General's Global Health Leaders Award recently, 2 years ago, and have been recognized for their outstanding contribution towards and protecting and promoting health. They have multiple roles, spanning across the whole family's health, from the newborn up to the mother, the family, even communicable diseases, as we're all aware. But focusing on ASHA and perinatal care, they are the important link for home-based newborn care, for Ashwabal Suraksha Karikram, for JSSK when they are accompanying the mothers for their ANC checks, encouraging them and getting incentives in return. Also helping in JSY when they are able to distribute medication tablets to these mothers. Coming to the other part of neonatology, which the government has also been increasingly focusing on, the family participative care. So I'd like to just share a question here. Are we all aware of IKMC? I would just like to see what is the level of awareness. Waiting for some more answers. Only 46% have responded yet. Okay, so most of, ma'am, may I end the poll? Shall I wait for some more time? So most of us are aware, but not practicing, and that's heartening. And yes, many are aware and practicing, and that's also very, very heartening. So to the so what is IKMC? Is immediately providing KMC to stable low birth weight infants, which was evaluated as a randomized control trial by the WHO in 5 hospitals in Ghana, India, Malawi, Nigeria, and Tanzania, to look at primary outcome being death at 28 days of life. And they had a staggering response that they had the babies who received stable babies who received KMC immediately post-birth were actually able to have a much lesser mortality. The trial was actually stopped early on the recommendation of the data and safety that this is beneficial to all babies, and so all the whole group should be taking benefit of the intervention. So all babies who received KMC actually were able to take KMC for around 17 to 20 hours, as opposed to the average of which is 5-6 hours per day in the standard, if you see the Indian NICU KMC hours. This was achieved through the paradigm of MNICO, the Mother Newborn Care Unit, where the mother and child both are receiving care for themselves, as opposed to mother being in the postnatal ward and baby being with us in the NICU. Both are housed or roomed in together, And this promotes not only faster breastfeeding, lesser hypothermia, mothers are able to give KMC for much longer times. Even there is better involvement and coordination amongst the OG and the pediatric department also, and ultimately shorter duration of stay in the NICU, because involvement of parents in care of NICUs consistently is better for the babies. So it has all the possible benefits and stands to be a very important resource of decreasing neonatal mortality in low resource settings, low resource NICUs, if being able to done properly. So coming to future directions, just like to ask one question here. Which of the following is possibly a quality improvement initiative for child health? So I think most of us have got it right. It is Muskan, yes. Lakshya is the quality improvement initiative for maternal health or labor associated quality as LA Lakshya. Suman is also for pregnant mothers, and Ma is also a program for promoting breastfeeding. So the inadequacies at present found were, as expected, limited availability of skilled resources, low coverage of services, and inadequate supportive vision, and low quality of training, and lack of focus on improving quality of services, which has been the forefront of by the MOHW. They have put forward quite a few quality improvement initiatives. Scope for improvement also exists at the level of ASHA workers, who often feel that they're not able to communicate well with the primary health workers, or in fact, sometimes don't even get the incentives for the work they're doing during JSS skin. They sometimes have to spend out of pocket as well. Many of them also feel that there is more scope for discussion and fine-tuning the programs as per the public's actual need. So Muskan, as discussed, was a QI for child health to reduce preventable mortality and morbidity amongst children, and to provide child-friendly services to newborn children in humane and supportive environments. So as the infrastructure is developing, and as the personnel are also getting trained, now the link between both to ensure smooth functioning, to promote adherence to evidence-based practices and standard protocols, many QIs have been put forth by the Government of India. And the scope can be applied at district hospitals, subject hospitals also, FRUs and CHCs, wherein all hospitals coming in contact with pediatric patients should be following at least these few interventions in the form of having a attendant and parent-friendly infrastructure, adequate referral services, respectful and dignified care, adequate communication, and following protocols. So many institutes can follow the checklist and get themselves approved as Muskan by the government, and even get incentives for the same. So coming to the other quality improvement initiative, Lakshya, that is for the pregnant mothers. As we know, more and more mothers are delivering in the hospitals, of course, but are they really being taken care of well? Is there dignity, and are their choices being honored completely? So respectful maternity care can only contribute and help not just the mother, but also the neonate's outcome. So improving quality of care at all levels, this operation has been at work with the objectives to reduce maternal neonatal newborn mortality, and to improve quality of care, and to enhance satisfaction of beneficiaries also. So do's and don'ts have been put forward just to ensure that the delivery process and the discharge process is more comfortable and safe for the mother. Coming to Mother's Absolute Affection, which is an intensified program to bring the focus on promotion of breastfeeding. As breastfeeding can prevent up to 20% newborn deaths. Despite 78% and 88% delivering in institutions, only half of those are actually initiating breastfeeding within 1 hour. And 64% only are exclusively breastfeeding in the first 6 months. So this program, through the help of media and programs and incentivization of lactation support services at public health facilities aims to increase awareness of breastfeeding and to increase the adherence for the same. So they want to achieve this by awareness generation, by mass media, community level intervention interactions, again, mobilizing the ASHA worker and the ANM, and monitoring and even giving awards and recognitions to high performing institutes and centers which are having good amount of breastfeeding rates. Also to go hand in hand with the MA program, we should also have a look at the Infant Milk Substitute Act, which was established in 1992 to regulate and to make sure that there is no advertisement or incentivization of other substitute over mother's milk. And any persons noted to be breaching these provisions shall be punishable because 12% of deaths among children fewer than 5 years of age occurs due to suboptimal breastfeeding practices. Coming to the latest initiative also for safe pregnancy, Surakshit Matritva Ashwasan, that is an initiative for zero preventable maternal newborn deaths. It's a grievance redressal and feedback portal set forward for all mothers who are receiving antenatal care in hospitals. Where mothers can go online and give feedback of their experience. And this system also integrates all the existing initiatives like Lakshya, JSSK, also has definitely a lot of scope in the future to streamline and better the programs as they work. So rounding it up, community health. Obviously, we're doing a lot at the level of capacity building and ongoing implementation, but quality improvement can take the whole journey forward. Along with what I would like to even suggest is definitely increase corporate responsibility. If institutes definitely can be encouraged to lend their precious time to be a part of resource building in so many programs, then definitely many more personnel can be trained and the bridge can be gapped. The gap can be bridged.
Thank you, Dr. Ishita. Any questions from any of you? Since a lot of postgraduates are there, I will just ask one or two questions. Can you guess the state Dr. Ishita was talking about MOB program, mother affection? So can you guess the state which is now holding #1 position for early initiation of skin contact and early initiation of breastfeeding? The current breastfeeding rate of India is 44%, and this particular state has got nearly 78%.
Chhattisgarh, sir.
Chhattisgarh, any other answer? You will never come up with this answer because we have not thought of this place as such a wonderful place which has got nearly 88% vaccination coverage. Two important things. We know that most common cause of neonatal death is low birth weight and preterm. Nutrition is coming important. Most common cause of infant mortality is pneumonia and diarrhea. Vaccination comes in picture. So two major things has been taken care of by one particular state. Sachin has come with Kerala, Meghalaya. Everybody wants to go to this place at least once in lifetime. Which place? This is a simple answer. Anybody who is doing MBBS would have gone as a batch trip to this place. The plan is on to this place. That's nothing to laugh. It's actually Goa. Goa has got 75% early initiation of breastfeeding, 75%, beyond Kerala 63%. And Deepak wants to go to Ladakh, but Ladakh there's no delivery, I think, happening. And vaccination also well covered. Jokes apart, every minute while we are talking, we are losing 2 babies globally. And the statement is very simple. If you are not making change in somebody's life, the life you are living is waste. So all of us has to take the pledge to save some children. Not necessarily you have to go there and save. When I attended FNC classes, now the sisters will be staying back till 7 o'clock, and I asked, "Are you not tired?" Then they tell one important thing is, "So nobody is come to taught us so depth like that." So never lose an opportunity to teach subordinate. Whenever you find a sister, teach something. This small teachings and small lessons can be life changing. You never know that people you may forget, but the best moment of a doctor is the time when a mother or father comes to you and tells this is a son or daughter you saved in your life. So the session is open for questions. Dr. Tulasi, Dr. Swati. Dr. Tulasi and Swati just classify all the programs Dr. Ishita has told in 4 broad headings: antenatal care, labor care, postnatal care, and sick newborn care. And Ishita just try to sum up and come with all 4 categories. I want Swati or Tulasi to come up with answers. Just make an attempt.
So you want us to answer classification?
Yeah,
according
classification. All the 4 category. Mother comes to you with the antenatal care. What are the programs? Mother comes to delivery room. What are the programs? Mother comes in the postnatal ward. You're doing rounds. What are the programs? And the baby comes to NIC or SNCU. What are the programs?
Okay, sir. So mother coming with Janani Shishu Suraksha Karyakram, JSSK. Then
Okay.
next step from there, we can go on to all the facility-based newborn cares that ma'am talked about, SNCU and NBSU, all that. Along with that, HPNC, home-based newborn care, and Indian Newborn Action Plan. Then along with this, still JSSK, then RBSK will still have a role here. And later on, IMNCI would come, sir. Along with the same time, the new programs, Ma, Suman would be involved as the mother's getting discharged and existing facilities. Then, yes, sir, that's around what I can do.
Tulasi?
Yes, sir. Whatever Swati said, along with that, on the whole, we will label them as this RMN TCI program. In that, we will label whether the newborn care and the mother newborn care unit. So in newborn care unit, we will have all the 3 care unit, the specialized newborn care unit and a newborn stabilization unit regarding that. Then for mother newborn care unit, we will have all the programs, including this JSSK, RBSK, then that facility-based IMNCI program. Then along with that, this home-based ones, family participatory care, which includes this immediate KMC care and all. And then for labor room care, this Lakshya will come, sir. Then for children care, MAS QAN program, and then Suman program as we discussed.
Okay, that shows how the message has gone to the audience. Okay. So where will you place NSSK? NSSK?
So natal, because it helps prevent the birth asphyxiation. Probably a little antenatal and natal to identify the high-risk mothers, refer to higher facility as well as natal.
Second most common cause is birth asphyxiation. So NSSK comes to picture. So all these programs, we may think that it's difficult to understand, but if you come across a story, it's very easy. You can write a short note in 10 minutes, about maximum 7 to 8 programs. Just remember and you can keep writing. Dr. Vishwanath, anything else you want to tell? Dr. Vishnu? Sashi, madam?
Sir, I had one doubt. Ma'am mentioned some ASHA visits guidelines after the 42nd day. Could ma'am again reiterate that?
Okay. Ishita, can you just go back to the Asha slide? Asha is a very important person in the healthcare system. She's not having a regular salary. Imagine a person working with so much of schemes. She's entirely given incentive. She's not having a regular salary. And she's mostly a widow or divorcee is selected. And she's a person who is from the community. The backbone of the system, apart from ANM, is the Asha work. So Dr. Ishita, can you just go back to the slide of Asha? Ishita, you have to unmute Ishita.
You're asking after the 42nd day, Swati, or up to how many visits up to 42nd day?
No, ma'am. After you mentioned something about weeks, I didn't get you there. So that
The weeks, I was talking about the duration, the frequency of the visits. Will be third day, 7th, and 14th is the second week. then 21-day third week, then 28-day fourth week, and then up to the 6 weeks when the immunization also will start. So up till 42 days, they should be able to track the baby at home. And by that time also encourage the mother to, after 42 days, she'll be coming to the hospital for the vaccination. And then she also will be linked up with the hospital. So till the baby is big enough for the mother and we both to go to the hospital, she should be visiting till the 42nd day at least.
Okay, ma'am. Understood. Both institutional and home, 42nd day.
Yes,
Okay.
both institutional and home deliveries. Because many mothers will deliver at institutes, but they will be lost to follow up. Many will delivering at home and they will not initiate follow up as it is. So both need to be sensitized.
Understood, ma'am. Thank you, ma'am.
Dr. Deepak and Dr. Shaishri, madam, can you give some comments? Anything you want to add on?
No, sir, it was good presentation, sir.
Madam, closing
Thank
comments,
you.
madam.
Nothing specific.
Okay.
I think it was a good presentation and good moderation.
I thank each and everyone for the active participation. And if there are no further questions, I thank Dr. Ishita for taking the wonderful session, and Dr. Swati, Dr. Tulasi for the active answers, and happy learning. Yeah. Good night.
Thank you all.